Good morning, everyone. Welcome to our first ever Educated Patient, a Liver Conference. This is the first of 2 days for this conference. We will be getting started just after 11:03 with Ivory Allison. So please make sure you're getting settled, go to the bathroom, and we look forward to getting started in just a couple minutes.
Good morning, everyone. We'd like to welcome you all to the Educated Patient, a Liver Conference. We're so excited to have all of you join us today for our first ever patient conference. Today will specifically be on liver cancer, and we have a phenomenal lineup for you today. We'd like to thank our sponsors who always continue to support us, and we could not do this without them. Bristol Myers Squibb, Eisai, Merck, and Alexis. Thank you for your continued support. Thank you again to all of our sponsors. A few housekeeping we'd like to go through today. Please remember to ask any questions. We will have 20-minute presentations followed by 20-minute Q&A. Use the live chat feature on the right side of your screen to ask questions. You must be logged into a Google account to take part in the live chat. And also, don't forget to join us after the program for a couch conversation. It'll be our very first one. We will share a Zoom meeting link in the live chat, again, on the right side of your screen, the conclusion of the presentations. And we look forward to all of you joining us afterwards for the couch conversation. Our first liver cancer community support group is on Facebook, and we would love to have all of you join us. The link will be in the chat. Some of you have already started following us and commenting, so we greatly appreciate it. This is a wonderful community for people to engage and get to know one another and provide information and share with each other. Again, the link will be in the chat. We have some wonderful events coming up this fall and winter, starting off with our Liver Life Walk. Will take place next weekend on Saturday, October 24th. Have you registered yet? I hope so. Let us know in the chat if you have. Make sure to go to the link if you haven't, which will be in the chat. Oh goodness, we have some incredible workshops coming up this fall and winter. Our mind-body workshops, as you can see listed. The first one on November 23rd, Mind, Body, and Healthcare, What's the Benefit? Followed by November 30th, Mind, Body, Coping with Liver Disease. Finally, the Physical and Mental Self-Management on December 2nd. Please, we would love to have you join us for any and all of these programs. You can email Lindsay Ventura, and her email will be in the chat. Oh goodness, is anyone hungry? Is it a little early, a little late yet? Cuisine for a Cause. Join us on November 21st for our most scrumptious program and event that we have. This is a phenomenal at-home culinary experience that you do not want to miss. You can follow the website, which again will be in the chat, and you can click and find out more information. If you haven't already registered, you can do so. And then you have the phenomenal opportunity to engage with us. We hope all of you are already engaging with us on our different social media platforms, such as Facebook, YouTube, you're already here with us today, Instagram, Twitter, and of course, LinkedIn. We look forward to seeing you guys interacting with us on all of these different platforms. And our agenda today, we are excited, as I mentioned, about this lineup that we have today. As you can see, we have so many different presenters from a range of institutions from across the country. And I think this will be an interactive opportunity for you guys to really learn a lot and engage with one another, including the presenters. Our committee, they have done a phenomenal job over the last few months putting this together. And we just want to thank them. Dr. Ghassan Abu Alfa from Memorial Sloan Kettering Cancer Center, Dr. Sheila Esrin from Rush University Medical Center, Dr. Jennifer Guy from California Pacific Medical Center, Dr. Tamar Taddy from Yale University, and Dr. Ali Zarampar from University of Florida Health. Thank you all for all of your work in putting this program together. I would now like to introduce Dr. Abu Alfa to give the opening remarks. He's going to do a phenomenal job today, and we're looking forward to it. Take it away, Dr. Abu Alfa.
Well, thanks so much, Ivory, and good morning, good afternoon, wherever you are for everybody. It's really very exciting. I wouldn't have dreamt of a day like this because, if anything, the American Liver Foundation have been doing an amazing job for endless number of years. And if anything, the advent of all what's going on in liver cancer really became a important focus, like many others that the foundation does. And if anything, I thank you all for being here with us today. And great thanks. I do second what Ivory said in regard to all the great colleagues that we are working together and continue to work together. I'll tell a little bit of a story about my story with liver cancer. And if anything, as you know, we go to our national meetings every year, and many of them happen in Chicago because this is like one of the biggest conference centers where it can accommodate all of us. And somebody asked me on the street, said, well, what do you do? And I said, I do liver cancer. The next question was, great weather today. That's really how limited it was. Sadly, because as we all know, 20 years ago, where I humbly started and I remained on that specific focus, like many of us, sadly, not much was there to help with. But nowadays, the major advance that we have in liver cancer that we owe mainly for our dear patients and loved ones is really what we should be all very proud of and very excited to be part of that team. A very important component, we're going to talk about many, many details, all of us during the day, but a very important component that's really very critical to remember is teamwork. And if anything, the multidisciplinary team approach that you're going to hear a lot of us talking about, where we as colleagues with different specialties, being the surgeons, being the transplant surgeons, being the interventional radiologist, being the hepatologist, being the gastroenterologist, the medical oncologist, the interventional radiologist, radiation oncologist, the psychosocial support, psychiatry, etc. We all are on the same table and we're all part of the same team. And if anything, our loved patients are part of that team as well, because after all, we really can always envision what's best for the patient when we are really all engaged together. And some data has shown that actually patients who are seen by more than one specialty will always fare better. So if anything, we are very excited. I know it's our first time, and sadly, nobody wanted the pandemic to come, but nonetheless, these are some of the things that we're learning and we're benefiting from as we go. And to have us all together today and tomorrow is really very exciting and very much look forward to it. With this said, you'll hear more from me as we move on forward, but I would like to pass it on to Dr. Tamar today, a great friend and great colleague. Really, I'm a big fan of all the great work of Dr. today, who's an associate professor of medicine in the section of digestive diseases at Yale University and staff hepatologist at the VA Connecticut Healthcare System in West Haven, Connecticut. She directs the liver cancer program at the VA Connecticut and runs a regional tumor board evening, Southern New England VA Medical Centers. Dr. Today is the associate director of the MD PhD program at Yale School of Medicine. And Dr. Today is board certified gastroenterologist with a certificate of added qualifications in transplant hepatology. And I'll pass it on to you, Tamar. Thank you.
Thanks, Ghassan, for that introduction. I really want to thank all of my colleagues that are here today. I'm, honored to be here and honored really to be among you all. And most important, honored to be with patients, because that's really what we do every day. We take care of patients. And in my opinion, not only is the team essential, but you're essential as the most valuable player on that team, right? This is your life. And our goal is to really care for you in a way that's compatible with the way you want to live your life. So my job today is really to give you a, liver cancer 101. So a so-called primer on liver cancer. And I think it's important to understand that liver cancer is a little unique among cancers. And the reason that it's unique is because it's one person, usually with two diseases, okay? So in the United States, upwards of 90% of people who develop liver cancer actually have underlying cirrhosis. And it's the cirrhosis and the liver disease that underlies the cancer that really governs a lot of our decisions as a team on what therapies are best for the liver cancer. Now, cirrhosis is a decades-long process by which the liver develops scarring. And the liver is a regenerative organ and it tries to regenerate. So there's a constant process of injury and repair. And in all of that is going on within the liver, oftentimes after scarring, which is considered a sort of coping mechanism that the liver takes on when it's trying to repair, you can develop cirrhosis, which is the final stage of scarring of the liver. And it's that scarring of the liver that actually gives rise to cancer. And so liver cancer most often arises in a liver that's damaged. And so our decisions have to really take into account how well the liver functions. Now, unfortunately, many people get diagnosed with cirrhosis and liver cancer simultaneously, which many patients have a very hard time understanding. How could I feel fine and you're telling me I have this cirrhosis and a liver cancer? And it's because the liver is a forgiving organ and a large organ. And so most people don't know they have problems with their liver until the scarring has reached a point where the liver doesn't function properly. And oftentimes at that point, they'll be recommended imaging for liver cancer. So every person with cirrhosis should have screening for liver cancer. And that screening is usually done in the form of an ultrasound every 6 months. And on ultrasound, we can see areas that are concerning for tumor. And then we usually follow that up with an image like an MRI or a CT scan. And so it's important to remember that if you have cirrhosis, you should be getting every 6 months surveillance. And we start, the first one is a screen, and then you are under surveillance. And that is usually done with ultrasound. Sometimes it's done with CT scan, sometimes it's done with MRI. But the bottom line is you should be being screened for cancer if you have the diagnosis of cirrhosis. Now, HCC, liver cancer, is really a unique cancer in another way, which is that it can be diagnosed by imaging alone. So in people with cirrhosis, these cancers look very characteristic. And by their patterns, we're able to say with nearly 99% certainty that this is an HCC. However, with new therapies coming down the pike, it may be reasonable to actually consider biopsy at some point, usually when a person goes from having early cancer to more advanced cancer. So it's the only solid organ malignancy that can be diagnosed by imaging alone, which makes it very unique. And it's also the only solid organ malignancy for which transplantation can offer a cure. So these are the 3 ways in which liver cancer is unique. Now, these 3 things actually come with consequences. So because the majority of people who develop HCC have cirrhosis, there have been limitations on how we've conducted science over time, because most clinical trials for cancers are developed with healthier populations. And so now we've gotten very good at developing clinical trials for people with liver cancer because we've changed the way that we've looked at those patients. We don't expect them to be healthy. We expect them to have liver disease. So we were a little bit late at the starting gate with clinical trials, and we're going to talk more about that during this conference. But generally speaking, we really have to consider the patient and their liver disease, because that's oftentimes the rate limiting step on whether a patient can actually have a given treatment, okay? So the cirrhosis is a big deal. It also gives rise to multiple tumors. So it's, in a way, you can think of cirrhosis as a field effect, because it's not just one part of the liver that gets scarred, it's the whole organ. And so the whole organ is essentially a fertile ground for the development of cancer. And so that not only leads to multiple cancers in the liver, but also very high recurrence rates. So many people who've been diagnosed with a cancer, say a year ago, could very easily have a recurrence and multiple recurrences over a lifetime. And so we need to really be vigilant, which is why it's so important once you have liver cancer to stay with your team and to get your imaging along the course of your care, which may be many years of care. So you really have to not only have a good team, but really have good team spirit, meaning you're going to come back and you're going to keep playing, right? So in addition to the cirrhosis and how it affects trial design and how it affects the cancer itself, the fact that we can diagnose this cancer by imaging alone means that we're also a little bit late to the starting gate of understanding biomarkers of the development of the cancer and the response to therapy. Because many other cancers, a biopsy is necessary. All of the revolution that we've seen in science has allowed us to actually study mutations in those cancers that could be targeted for treatments. And we really don't have that quite yet in liver cancer, although we are getting there. So we've seen a lot of dramatic improvement in our understanding of this cancer over the last 5 to 10 years. And we really have already seen multiple drugs come to market that are promising. So we're getting there, but we're a little behind the curve. And because it's the only solid organ malignancy that can be cured by transplant, the onus is on the hepatologist to really be able to decide who could have that life-saving therapy. And we all know that there aren't enough organs to go around for everybody waiting on the list, and that there are very careful rules that govern who can get a transplant for liver cancer. And oftentimes patients can progress, meaning their liver cancer can worsen while they're waiting on the list, and they may actually be removed from the list. But that's not the end of the world. There are still many other therapies that can be offered to that patient. But that can be very disruptive to a patient and their family if they've been sort of holding out hope for a transplant, sometimes for many years, and then they have, worsening of the cancer and they're taken off the list. And many times that leads to a switch in the players on the team. It doesn't necessarily mean that you have to join a new team, but it just means that there may be different positions that are filled by different people. And that's what's really important. Liver cancer should be treated in a tertiary care center where you have a team of specialists who understand the continuum of liver cancer, no matter when you're diagnosed. If you're diagnosed with early stage disease and you're followed for many years, if you're diagnosed with intermediate stage disease and you're followed, or advanced, you should have a team of people who understand your stage of disease and who understand all of the options that can benefit you. Now, having said stage of disease, this leads to another major issue, which is, what is my stage? Everybody always wants to know, what is my stage? And although we have many staging systems, it's really important to understand that your liver disease often determines the therapy you can get, and that the stage, although there are many staging systems, is usually thought of as early, intermediate, or advanced. And the different therapies are for different stages, okay? So I think people tend to get very caught up in staging because it gives them a sense of control. But I think the most important questions for patients to ask their doctors is, is this the right therapy for me? And what made you come to that conclusion? And you'll find that most of us come to that conclusion in a tumor board, in a multidisciplinary environment where we talk about your case with many experts and really think about, what's the best treatment? Could there be a clinical trial that you would benefit from, et cetera? So I think those are really the most important pieces. One thing that I really want you to come away from this is that you're not alone, okay? So there will be 42,000 new liver cancers diagnosed in the United States this year, okay? There are 850,000 diagnoses of HCC across the globe this year. You're not alone. And we understand that this is a very important cancer that desperately needs science to move with it so that we can offer better therapies. And many of us spend most of our time actually working on taking care of patients and developing studies so that we can make life better and last longer with very good quality of life. And I think it's important, as we were talking about teams, as Dr. Abu Alfa said, that we really think about what's important to you as a patient. So having discussions about what matters to you, about what you enjoy doing, about what, sort of feeds your soul, so to speak, is really important. And I can't, stress that enough. You need to really share with your physicians and with your whole team, what it is that you enjoy in life, what you want to do, what's important to your family, et cetera. Because I think a lot of times we have these very sterile encounters with our patients where they're really, the patient's afraid, their family's overwhelmed, there's a lot of information. And I think it's really important to know that we're people too. And actually, we really want you to reach out to us. And we know that after you leave our offices, you may have a million questions, and that's okay. We're a phone call away. And we usually have really good teams of nurses and care coordinators that can help you with questions if we're not reachable. And so this is something I really want you to keep in mind. We have a team, we're your team, and you need to keep the lines of communication open, no matter who you hear from today. And we're a panel that really spans the entire country, from East Coast to West Coast and in between. It's really important that you understand that you're the most valuable player of this team that you're on, okay? And that your team can answer your questions, even if they happen to come to your mind after you've left your appointment. So I'm going to stop there, and I think it's important to take questions. So I'd like to open it up to questions. I think that Jennifer's going to moderate the question and answer session. So take it away, Jennifer.
Thank you so much. That was wonderful. So we have some great questions coming in, and I wanted to start with one. You talked about how scans can look for liver cancer. Are there blood tests, patients are wondering, that can also be helpful?
So there is a biomarker for liver cancer called alpha fetoprotein, which is a blood test. It helps if it's positive in the diagnosis, but it doesn't help if it's negative, because many patients with liver cancer actually will not secrete this protein into their bloodstream until the cancer is very advanced. So while it is a biomarker, and biomarkers are difficult to develop, so we're happy we have one, it's very insensitive. Now, there are a lot of labs that are and scientists working on what's called liquid biopsy, where they would take a person's blood and be able to find circulating tumor cells. That science, I think, will be developed over time. It's not available yet, but we hope in the future that there will be more biomarkers so that we can catch this cancer at its earliest stage. We're not there yet. We have a lot of hope for it. But I would say that the existing biomarkers that we have, and some of the biomarker panels that include alpha fetoprotein, are still too insensitive for us to really say we can make the diagnosis based on this biomarker.
Thank you. And another question that came up is, with the scans, what's the difference between a CT scan or an MRI? Do you get different information with them? How do you think about them?
So an MRI is by far and away the most sensitive test for HCC. It is a long test. The proper protocol takes about 45 minutes. You have to be in a tube and you have to hold your breath. And the tube, the magnet itself makes noise, which can be disconcerting to some. However, I would argue that most MRI machines now, the tech will offer you either earplugs or headphones that can pipe in music. You can get a mild sedative. So if you've been afraid to get an MRI, I can certainly understand that, but they're actually probably the best test to make the diagnosis. They're not a screening test. Ultrasound is really the screening test, but MRI is really very sensitive. CT scan is quite sensitive. So it's a very good test. And it definitely shows us the same characteristics that we would see on an MRI. The difference with CT is that it involves iodinated contrast, which can be toxic to the kidneys in patients who have kidney disease, so we're careful about that. It also involves radiation. So MRI has the benefit of using a contrast agent that is less likely to cause kidney disease, even in patients with kidney disease. And it does not involve radiation, which many people would think is superior, because if you're going to be imaged periodically, you probably want to limit your exposure to radiation. So we do prefer MRI in diagnosis and treatment follow-up. But if you have a contraindication to MRI, which some people have, if you have, for example, MRI incompatible pacemaker, for example, we wouldn't put you in an MRI machine. So that's really the difference. We have to think about the patient. We have to think about sort of the limitations of either modality.
Thank you. And to follow up on radiology tests, can you talk a bit about, when you see a patient, are you getting chest CT scans, bone scans? People are wondering about staging for liver cancer. Where could it spread and how do we look for that?
So liver cancer, the most common places for spread are the lungs and the bones. And to be listed for transplant, for example, with liver cancer, you must have a chest CT. And most tumor boards agree that a chest CT is necessary at the time of diagnosis to exclude pulmonary metastasis, because that is the most commonplace. Generally speaking, it's rare to see lung metastases in people who have a small single liver cancer, but it's still important to get that index scan. Bone scans generally are reserved for people who actually have more advanced disease at presentation or actually have symptoms of bone metastases. The United Network for Organ Sharing used to require a bone scan for listing for liver transplantation. They don't anymore. So I would say that it really depends on the stage at which you're diagnosed and whether you have any presenting symptoms. But a chest CT, all societies would agree, is important to complete staging if you have the diagnosis of liver cancer.
Thank you. Moving from diagnosis to risks for developing liver cancer, there's a question from the audience. I know NASH, non-alcoholic fatty liver disease, can cause liver cancer. I have it and so does my mom. Is this hereditary? Should my siblings be concerned about liver cancer and NASH?
So that's an excellent question. So NASH is non-alcoholic steatohepatitis, which is a form of fatty liver that involves inflammation and usually scarring. And people with NASH are a small subset of those patients will go on to develop cirrhosis. Now, what we're seeing, which makes us a little bit concerned, is that there are people with NASH without cirrhosis. They may have advanced fibrosis, but not cirrhosis, who can develop HCC. We don't have screening guidelines for these patients because NASH is somewhat of an evolving disease. We think that people with fatty liver disease have usually metabolic risk factors like hypertension, being overweight, having a high lipid profile, for example, even though we know that people, even lean people, can get fatty liver disease. So we're still trying to understand this disease and what the risk factors are for the development of cirrhosis and cancer. I think it's very important to know that this is a rapidly evolving field and that, you know, even before people, you know, we think about cancer therapies, right? Especially if you're struggling with cancer, but a lot of people are actually working upstream of cancer therapies and thinking about therapies to prevent that scarring. They're so-called antifibrotics, which may have a significant role in people with fatty liver disease. So I think epidemiologically speaking, when you look at populations and what's shifting in liver cancer, we definitely see that this cancer is happening in people with fatty liver disease. Before, we used to think it was really predominantly hepatitis B and hepatitis C, and we know that viruses can cause cancer or at least contribute to cancer development. But clearly that inflammation that's caused by metabolic disturbance can also lead to cancer. Now, whether it's hereditary is really debatable. I think a lot of it is nature and nurture. So when I say nature, you know, if your mother has type 2 diabetes, it's very likely you'll have type 2 diabetes. But a lot of the things that your mother might have done, you know, in terms of her managing her own weight or exercise, et cetera, may have actually, that genetic predisposition for type 2 diabetes, it might have been enhanced perhaps by a sedentary lifestyle or being overweight. So you may have some genetic predisposition, so to speak, but there are still lifestyle modifications that you and every patient with NASH can take. So if you have diabetes, you need to get into tight glycemic control. If you're overweight, you need to really change your lifestyle and think about what you eat, but also become more active. And I hate the word diet. I think diet is a temporary thing. I'm really talking about lifestyle modifications. And we all know that people who are overweight have a twofold increased risk of liver cancer, regardless of other risk factors, viral, cirrhosis, anything like that. So I would say the most important thing to focus on is staying lean or getting lean if you're not. And then if you have diabetes, controlling your diabetes. And if you have high lipids or high cholesterol, really talking to your doctor about how to fix that either by diet or by medication. So that's a very long-winded answer to that question. I do think it's a very important question. And, people always say, well, if you're going to marry a woman, look at their mother, right? Because they think, oh, she's going to end up looking like your mother. And I think there's a kernel of truth in that. We tend to live together, eat together, love the same foods together. And so you'll see that, it's not inconceivable that if your mom is, overweight, that you may be too. So these are things that you can do together. You can say, hey, let's do this together. But there's no doubt that our society as a whole really needs to work on their weight. And we do think that some of the shift in the increase in the incidence of liver cancer in the United States is because of our increasing obesity.
I think that's just a beautiful description of a really complicated topic. And what I would say is, we had some introductions to some mindful practice seminars that are going to be happening through ALF. And I think I agree with the word diet. That can be, off-putting, but this idea of mindfulness practices. And I think what you just mentioned is how important prevention is in terms of liver disease. And so I think that everyone should really be seeing if they can join in on those webinars as well. Another question that came up was, could you talk a little bit more about hepatitis B and how hepatitis B is related to liver cancer?
Yes. So hepatitis B is in itself a World Health Organization carcinogen. So we know that hepatitis B causes cancer. Hepatitis B can cause cancer, liver cancer in a person without cirrhosis, which is why people with chronic hepatitis B should be screened with ultrasound every 6 months. There are particular guidelines that govern sort of when you might have acquired hepatitis C, and if you have any family history, hepatitis B, or if you have any family history of cancer, in your family of a relative who had hepatitis B, you might need to start screening a little bit earlier. But generally speaking, people will say, well, if it's a carcinogen, shouldn't I be on hepatitis B treatment like right away? And the truth is that we actually have very clear guidelines on who should and should not be treated for hepatitis B. A lot of it depends on how old you are, your childbearing potential, and whether you have advanced fibrosis. People with advanced fibrosis should be treated for their hepatitis B because it does mitigate the risk. It lessens the risk of developing liver cancer. So I would say that hepatitis B, chronic hepatitis B, is the only patient population that is advised liver cancer screening every 6 months with ultrasound in the absence of cirrhosis.
That's an excellent point. And I think going back to the fatty liver question as well, the idea that when you have fibrosis, there is a different way of thinking about just the risk of cancer as compared to when you don't. So seeing a liver doctor to really understand where in the spectrum of fatty liver disease you may be, additionally understanding where in the spectrum of hepatitis B you may be, could be very helpful in thinking about your risk of liver cancer. Moving along to some questions about if I have liver cancer. Do you recommend any specific diet or lifestyle behaviors that I should be undertaking?
So I think that's an excellent question. And there's a lot you can read out there about different cancer diets. I think actually when you have a diagnosis of cancer and you're trying to sort of fit your life around the schedule of your appointments and everything else, trying to follow a very rigorous diet can be very, very difficult and probably disruptive in a way. I think the most important thing to do is to eat a healthy, balanced diet with, a good amount of protein, fresh vegetables, fresh fruit, limited fats, but good fats like olive oil and avocado and nuts, for example. And, a dessert here or there, but not every meal every day of the week, right? So I think eating in moderation is important. I think if you have cirrhosis, what is really important is that you maintain your muscle mass and that you eat a diet that has enough protein in it. So essentially, for most people with cirrhosis, you need at least 1 gram per kilogram. If you have cirrhosis that has already kind of converted to what we call decompensated cirrhosis, if you've developed ascites or fluid in your abdomen, And if you actually notice that your muscles are becoming smaller and essentially you're losing, I usually look at your shoulders, have a lot of muscle. And, when you start to lose muscle, you start to see sort of a hollowed out clavicular area, that kind of thing. So if you look at yourself in the mirror and say, I look like I'm losing muscle, you need to eat more protein. So people who have protein loss or muscle loss, we really want to get them more towards like almost 1.2 to 1.5 grams per kilogram of protein a day. The other thing is, how do you maintain muscle mass? And really, they're very simple activities to maintain muscle mass that you can do in, watching commercials, right? So squats are wonderful activities. So if you can cross your hands over your shoulders and stand up from a seated position, that's a squat, okay? If you do 10 of those during a commercial break, and you watch a couple hours of TV, you're going to be really strong. You're going to really maintain your legs, the strength in your legs and your quads and your hamstrings. And then if you do push-ups, even against a wall, I'm not saying military style, you're going to maintain the muscle mass in your shoulders and your chest, the big muscle groups, right? You really have to work at this because liver disease and cirrhosis in particular tends to rob a person of their muscles because the liver doesn't make proteins as well as it used to, and the body tends to use up other sources of protein, and the muscles are the major source, right? So squats, push-ups against a wall, planks, which are really good at kind of isometrically managing all big muscle groups, but also your core. You can do them. I challenge you, just do them during commercial breaks. You will see that you will maintain your muscle mass. You may get stronger. And certainly if you're eating enough protein, then you probably will get stronger because you're able to lay down muscle. It's also very important to drive home this notion that most people with liver cancer, the peak incidence is in their 60s, okay? And that's right when we actually start to naturally lose muscle. We actually start in our 50s, but in the 60s, you begin to notice it, and actually you begin to lose balance as well. And so to be really fit, to prevent falls, to have a good life where you can go hiking, get down on the floor with your grandkids, reach up for that, whatever's in the cabinet, you really need to stay strong. And these are just simple pieces of advice that will help you, cancer or no cancer. Because ideally, and many people with liver cancer live with that liver cancer for years, and you need to stay strong.
Wonderful. Dr. Teddy, this has been so helpful. We're going to follow up with this final question, which is, you've been talking about how important it is to be part of a team. And some patients are wondering, what is the most effective way to communicate effectively with the team? Sometimes patients worry that they're bothering their care team by reaching out. So can you give some sort of pearls as to how that works best for you and your patients?
So I think every team is different in how they like to communicate. And now we have electronic health records, which allow us to communicate electronically. So oftentimes we'll have a particular clinic address where the patient can email, and then there's usually a pool of nurses who can triage those emails if they feel confident. If not, they reach out to the physician. So, I would actually really ask your team, what's the most effective method of communication? So for example, I work in a VA system where there's an electronic platform where I actually am mandated to answer that query within 24 hours. And so that's great. It's much easier than getting me on the phone. And usually if the query is an important one, I'll just pick up the phone. So I think you really should ask. A lot of times when you're a new patient, they'll give you a new patient packet, which kind of goes over those things. But if you don't get it, or if they don't have something like that, you really ought to say, I'm going to have questions after I leave here today. How do I communicate most effectively with you? And the other thing is write down your questions, right? I mean, your mind is swirling. You probably got family with you. Their minds are swirling. And questions will come and they'll leave just as quickly as they came into your head. So write down your questions. It helps to focus the visit. It helps to kind of give us a sense of how much we can bite off in that visit. If you have 40 questions and I can prioritize them, then I'm going to say, today we're going to handle these 5 questions, which are really important questions. And we're going to handle the next 5 on the next visit, that kind of thing. So it definitely helps to set an agenda that way. I think writing your questions down is really important. And I think that you really, I mean, again, you're the most valuable player. This is your life. You are the patient. We are here to serve you, and we want to answer your questions. And I think that's really important. Proactive patients are wonderful. I think patients who ask questions and who really want to be part of the dialogue, we really welcome. And I think that the more involved you are in your care, the better. There are never too many questions.
Excellent. Well, thank you.
Sure, my pleasure. All right. I think we are a little bit ahead of schedule, which is probably a good thing. So it's my great pleasure to also introduce my great friend, Ghassan Abu Alfa. Dr. Abu Alfa is a board-certified medical oncologist who treats patients with gastrointestinal cancers, and his specialization is in primary liver cancer or hepatocellular carcinoma, but also gallbladder and bile duct tumors, the pancreas, and fibrolamellar carcinoma. As part of a multidisciplinary group, he and his colleagues offer patients a team approach to treating these cancers. Dr. Abu Alfa is on our National Medical Advisory Committee, and he has really been a pioneer in the development of clinical trials for HCC. Many of his papers have changed the way we manage this disease, and it's an absolute honor to be here with him today. Thanks, Ghassan.
Thanks so much, Tamar, and thanks so much. Great learning as always from you. And to carry on, and if anything, add to what Dr. today just told us all about the disease. Understandably, now the disease is there. What shall we do about it? And I definitely second what we heard already about the curative approaches, where we really get rid of the cancer, hope that it will never recur, and of course, patients will move on without any recurrence of the cancer. Understandably, this is applicable through three methodologies. One of them is surgery. The other one is radiofrequency ablation. And the third one is liver transplant. No doubt that it's not a pick and choose kind of thing, but rather what is applicable for a specific patient is based on as we heard from Dr. today, is what is the liver function like? And number two, of course, the location, size, and involvement of the cancer per se. Be assured that your physician always will make sure to give you the appropriate approach. And yes, there could be, and kind of, these are real questions that we get from our patients. What if, or what is another opinion could be in that regard? By all means, we do understand that a certain perspective might differ between physicians, and by all means, you can always broaden your opportunities. But please always start with your physician and say, I read this, or I heard that, or is this really the only way to do this? And I'm sure they can guide you accordingly, and will try to kind of explain why what they are offering is really the appropriate approach to go. The idea that the curative intent is to get rid of the cancer is very solid. We like it, we support it, and always is really what we aspire for as well as physicians. But understandably, we do understand the limitation of this, where sadly, either a recurrence of that cancer might happen, or even a de novo, another cancer evolve in the liver as well. Because the liver, when it's sick, as we heard from Dr. today, can really have the ability to brew other cancers per se. And that's really why sometimes the argument might be in favor, of course, of a transplant rather than a surgery, because you want to get rid of the poor environment or the bad environment that can help or evolve into developing the cancer. Sadly, though, when these recurrences happen, or if they don't occur, they happen de novo, or more importantly, if the patient is not eligible for any of those potentially curative intents, being, as we said, surgery, radiofrequency ablation, or transplant, then let's assume that we are now dealing with a locally advanced disease. In other words, it's a cancer that's still confined to the liver, but it's not within the context of either dimensions or size for transplant, or number two, it is not within the confines of a surgical resection because of involvement or closeness to certain critical structure, like, for example, a blood vessel or what have we. This is where local therapy can come into play. And local therapy, if anything, there are many variants of it, and your physician might favor one or the other based on either the read of the data, which is fair. Number two is their experience, which is also very fair. And nonetheless, again, always make sure, please, that you ask the questions. Why this? Why not that? Nonetheless, you'll mostly hear, and you probably many of you have heard about something called chemoembolization, which pretty much is a form of trying to kill the tumor by cutting the blood supply from it. Why we call it chemoembolization? Because along with that path, we give chemotherapy with it as well. Why can we do that? We can do that because, as sad as it is that we have liver cancer, but there's a big virtue in livers that it has two blood supplies. One of them is the pure blood, which is the one that comes through what we call the arteries or the arterial supply. In addition to that, the other supply is what we call the venous blood, because as part of how we are made and how we live, all the blood below the liver will pass through the liver, get cleaned up before it goes to the heart. The drug, the cancer, remember that, is very finicky, always live on super clean blood. They always live on the arterial supply. And as such, if we were to cut the blood supply by what we call embolization, small kind of spheres that will cut the blood supply to the tumor in the arterial blood, even though this is the one that, supports the liver, because we have the venous blood, this of course will make up for that cutting supply, and as such, our liver continue to be alive and doing well. Now, there are variants of that chemoembolization. You're probably going to hear about them here and there. No doubt you can do it without the chemotherapy. Actually, some very few centers that actually focus on doing what you call bland embolization, based on some data that showed there's not much of a difference between the two. Nonetheless, this is really not necessarily advised one versus the other. They are equal. And remember, I said that what your doctor is most comfortable with as well. And the third one, which is relatively more novel, is what we call radioembolization, where we pretty much, rather than giving the bland beads, now they're actually embedded with radiation therapy that can emanate more effect by the radiation effect that it can give when the embolization occurs. Most important, please, is, as we said, ensure a certain important discussion with your physician is ongoing in regard to the treatment, and make sure that you understand what are the pluses and minuses. And please do remember, sadly, as much as we would like to say otherwise, but sadly, the embolization are not curative. Yes, there could be rare instances, and of course, we are super delighted and happy to see them where the embolization might be curative, but sadly, most of the time, it's not. And in other words, a certain need for more embolization can occur. Certain opportunities to try to enhance further embolizations are happening and ongoing clinical trial, but there's none of them are standard. Some efforts in regard to combine, for example, what we call systemic therapy, which I'll talk about in a sec, plus embolization have been tried, but so far we don't have any robust answer where we can tell you for sure do it and add what we call a biologic therapy or a targeted therapy or an immunotherapy or whatever it is to the embolization. This is not there yet. And it's important also to remember that if the disease is outside the liver, even in a teeny-weeny spot here or there, let's say in the lung or what have we, the embolization might not necessarily be the right treatment approach, and systemic therapy will be very critical in that setting. We are not there yet to really split the beans and say, okay, we'll treat the liver in regard to the local therapy, and we'll treat the systemic therapy at the same time with systemic disease, systemic treatment for the systemic disease. We have some data that has been looked into, but we don't have yet this as a standard. The minute, sadly, the disease is inside the liver, there's where systemic therapy comes into play. Now, 20 years ago, I can assure you that if one of my colleagues in interventional radiology is to tell a patient or one of our patients, go see the medical oncologist, it looked like it's doom and gloom, as if I can't offer anything else, and you're sending me now to the medical oncologist because they're going to talk about chemotherapy, it means it's bad news. Sadly, I can understand this 20 years ago, but nowadays it's not. And if anything, the medical oncologists have a lot to offer. And this is like really an incredible time in regard to how much has to be offered to our patients with with the systemic disease, and among which, of course, chemotherapy plus others. Now, chemotherapy in general is more of like a misnomer. Same way we say antibiotics. You say, I have an infection. You say, he's taking antibiotics. But as we all know, antibiotics are like an endless number, and there's many of them. Some of them work for this bacteria, others work for that bacteria. Some of them work for that infection of that organ, for another organ. So same thing for chemotherapy. It's not like just everything. And in general, medical oncologists by default, because this is really the first thing that they treated with back in the 60s is chemotherapy, were called the chemotherapy guys. But it's not really the only thing we do. Actually, ironically, in, for example, liver cancer, we rarely use chemotherapy. I would say rarely because if any of our audience today are from China, I will not be surprised, because there has been great work that was published in China, and it's actually a standard where they can give some chemotherapy. In addition to that, we have tried it ourselves as part of certain clinical trials here in the US or in other parts of the world as well. However, the key focus that we have in regard to systemic therapy have been what we call the biologic therapy or targeted therapy. In simple terms, as such, as kind of like Dr. Today just in the first introduction brought up to us, think about it this way. The cancer or your cells, rather, your liver cells are sitting down and typing on the typewriter, and it's 4 o'clock in the afternoon, get tired, you push P instead of B. That genetic alteration can lead to certain different message that ultimately will cause those cancer cells to start growing or becoming cancer cells, and they start growing. Now we know that certain genetic changes of that nature, and not necessarily specific, like targeted as a pure targeted component, but at least we know that they address those specific genetic changes. We have therapies for them. And you are very familiar with them. Many drugs. Will avoid to name any of them because respectfully, there are too many of them. We don't want to kind of like play the favorite, because we don't ever do that. But nonetheless, we kind of like call them collectively in a category called tyrosine kinase inhibitors. They are the inhibitor. They prevent what we call tyrosine kinase. It's a certain driver. Kinase is an enzyme that will kind of cause the cancer cells to grow, and we simply just stop them there. In simple terms, it's like a key and a lock. Like, you have a certain lock and it's open, the cancer cells are growing. You bring in the key, which is the tyrosine kinase, you lock the key, and that will be it. We did depend on the tyrosine kinase inhibitors quite a bit in time. Actually, they've been with us for literally almost close to about 15 years now. And they evolved quite a bit from really very limited option to many options nowadays, that include actually therapies that we provide not only as a first treatment in regard to systemic therapy, but you will be familiar with, and you are familiar with, a statement that your doctor might say, second line therapy or third line therapy. In other words, what happen as treatment number 1, what can happen as treatment number 2, if treatment number 1 did not work, or the cancer grew on treatment number 1, I can move to number 2, number 3. And that's, please, a kind reminder to all of us that we never should give up when we hear a news like tumor grew. We always, and thankfully, we have so many options to offer nowadays. And this brings me actually to another very hot item that I'm sure all of you are familiar with, which is immunotherapy. Immunotherapy is rather a latecomer to liver cancer because there was always a fear, as Dr. Today just told us, about hepatitis. And if I'm going to do immunotherapy, can I reactivate the hepatitis? So these are like fears that we had, relatively speaking, in the beginning. But then we had a better understanding about the whole process, enough that now immunotherapy is a critical component of the treatment for liver cancer. And if anything, we did discover that the immunotherapy, when we just don't combine it with anything else, doesn't work great. It can, but it's not really the one that we aspire for. And by the way, to explain like exactly why or what happens exactly, think about it this way. The cancer cell, kind of make a contract and say to the immune system, you know what, we will not bother you, just don't bother us. And as such, the immune cells will kind of come close to the cancer cell and they don't touch it. That's really what happens. So how can we make our immune cells fight the cancer cell? Interestingly, think about it this way. Think that the cancer cell, out of kindness, will build in a chair on its tumor membrane, and that tumor cell will the immune cell will sit on that chair, unable to touch the cancer cell. And simply, all what immunotherapy is, nothing more than just kicking out that chair so the immune cell can fall onto the cancer cell. That's all what it is. These things that you hear about and you fancy yourself about, PD-1, anti-PD-1, anti-PD-L1, actually PD-1 is nothing more than a chair, and PD-L1 is nothing more than a crane. And you just dismantle the chair and the crane, and the immune cells can do their job. On the other hand, though, we discovered that this is not enough, because technically you need a phone call from upstairs. Upstairs is actually the lymph nodes. And there's a certain passage that happen from the lymph nodes all the way to tumor cells that things can be exaggerated further to let this activity happen. And if anything, a different path stops, you can have further activation. And you'll hear about things like VEGF or anti-vascular endothelial growth factor. You talk about FGF, fibroblast growth factor. You talk even about other immunotherapies, because interestingly, on top of the ladder in the immune cells, interestingly, certain immune cells will kind of like activate themselves, but others might hijack that activation from them, and kind of like there's this guy that will tell them, you know what, let me give you that drink, let you kind of, have good time. And of course they fall asleep. They give them something that will make them fall asleep. And this is when one of the immune new therapies will pull them out and let them activate themselves. You know what I just did? I simply just told you about the Nobel Prize that was just won last year for immunotherapy. This is what Dr. Jim Allison really brought up to us and to the world. So, and this is, by the way, is already looked at and being looked at in regard to the immunotherapy for liver cancer. Lastly, and more importantly, I like very much to second what we heard already from Dr. today. Remember one thing, always everything remains on the table. We're always happy to kind of like discuss back and forth and even bring our colleagues from the different disciplines to really see what's going on. But please, I would urge always never lose hope. The most important though is the idea is not like I have one problem, let me just get rid of it and move on, but rather it's a little bit more of living with the problem, because as we can see, this short of those opportunities that sadly are not always available for resection, for radiofrequency ablation and transplant, the rest of the disease might very well be with us, and we have to learn how to live with it. And there are definitely very critical approaches to live into this and how to work it accordingly. You'll notice your doctor is not necessarily always thinking about what I'm going to do tomorrow. They're going to always think way ahead of you and see how they can keep you alive, because there's really what we're after is to keep you as good as you can be and as functional as you can be. That's really the aim of the therapy, not to get rid of the cancer. Of course, we would like to control the cancer, but even controlling it is something that really can keep us functional. Sadly, it comes at cost. We're not going to say no, but still, nonetheless, we still can do the best we can to keep you as functional as you can for your ongoing life and what you really like to do, or work, or family and loved ones. I'll pause here, and I definitely welcome questions. I know that Dr. Jennifer Guy is going to bring us again to a Q&A. Thank you very much, Jennifer.
Thank you, Dr. Abu Alfa. That again, this has been such a wonderful morning already. We've got some questions here, and one question is, as Dr. Tadai said about the spectrum of underlying liver disease and the spectrum of stage, there's also a spectrum of treatment. How do you think about moving from more liver-directed therapies, like, for example, the radioembolization, chemoembolization, ablation, to more of the systemic therapies? What might that look like for a patient?
Great question. Thank you, Jennifer. And thanks for whoever asked the question. So as already I implied, the movement from a local therapy to systemic therapy is more of a continuum or a spectrum of processes. And if anything, the great collaboration that we all have among among the group of the different disciplines, we kind of like prep the patient for those potential opportunities as they come. If anything, the perception from a patient view is local therapy, I do it, I'm away, I don't show up until several months afterwards. We like that. But if anything, the systemic therapy might require a little bit more of a closer friendship with your doctors, where you come a little bit more often than usual. And of course, you will be monitored a little bit more closely in regard to your liver function and some other components in regard to, for example, your blood work, in case you're getting some therapy that might affect it, or in regard to some other side effects that can happen from immunotherapy, like your thyroid function, etc. Nonetheless, it's very important to remember, as I already implied, that it does not mean that you're coming to those doctors. It means that that's it, life is over. Absolutely not. If anything, always we tell our patients when they are on systemic therapy, just we're going to steal probably a few hours from your day or maybe half a day, but we would like to keep the rest of the days for you. And that's really the aim, is to keep you as functional as possible while we're giving the therapies that are needed per se. So please, I urge everybody not to misperceive that if I'm moving from local therapy to systemic therapy as if it is like the end of it or bad news. Absolutely, it's not.
And I want to just reiterate that's such an important point, because as we see more and more biologic and immune therapies, systemic therapies, as you say, coming online, we see that patients continue to do better and better and better with every year that we're taking care of them. So I agree, this idea of hope and options is very much alive for all cancer patients. A question here about radioembolization. Can you talk a little bit about how radioembolization works?
Great. So I, of course, respectfully, I'm not the expert, so I'll do my best. And never you, especially patients who receive that, they might be even more expert than me. But the same concept that I brought up about the dual blood supply will still apply over here. And we give it another through the arterial blood supply. And if anything, those little beads have radiation therapy on them. They will definitely work on blockading the blood supply to the tumor, wherever the tumor is. And this is where the embolization come into play, because you're sending an embolus or something that will block the blood supply. And same time, that kind of bead has this radiation emission on it that will actually radiate and will be able to actually exert the radiation effect that, as we know from the radiation therapy, can exert its effect and cause the cancer cells to be killed. That's really the component of it.
Exactly. And I described to my patients that the radiation beads are tiny little beads that travel to the smallest capillaries that provide nutrients to the cancer and kill those blood vessels, and by doing so, kill the cells. Excellent. So moving along to a question about chemoembolization. Someone's asking, did I hear correctly that chemoembolization is not curative, but will it slow the growth of therapy? And could immunotherapy alone completely stop or shrink or cure a cancer?
A beautiful question. So as you noticed, yes, I said very clearly that chemoembolization should not be perceived as a curative therapy, but nonetheless, I gave that a component of exceptions might occur here and there, but you should not really put it as an aspiration that that's it, is what you want to achieve, because you never want to be disappointed. And remember, I tried to delineate very clearly that cure versus no cure is not the yes and no kind of component, because, you know, maybe a little bit less dramatic, but for example, we don't cure diabetes, we don't cure hypertension, but people live with them. And that's really our job, is to really keep people alive with the cancer. Now, to go back to the point that you brought up in regard to the chemoembolization, can it be perceived as better or worse than immunotherapy? Absolutely, there's no comparison here, because to be fair, this is applicable in one setting and the other one is applicable in another setting. And if anything, it's not really a pick and choose kind of thing. If the disease is local and it's applicable for chemoembolization, by all means, is the right thing to do. On the other hand, if the disease is systemic, this is where we go to immunotherapy. Now, along that line, could immunotherapy cause a cure per se? In some of the research that has been done, and this is already published, yes, there has been what we call complete response. Remember, the word cure is actually dependent on a very important variable. It's dependent on time. Because when we say complete response, this is a dimensional variable. We are saying that there's nothing I can see on the CAT scan or MRI or what have we. But when we say I'm cured, it means there's nothing that has happened over a certain period of time. In general, in oncology, across the board, we define cure as being something without any action of the cancer for 5 years. And you can probably claim a cure after 5 years. Are there potential for checkpoint inhibitors, what we call immunotherapy, for causing that? We didn't really see that yet, because remember, this is relatively new for all of us in the last several years. But nonetheless, the start of it was a complete response. Yes, we have seen it. Can I say this is the example or this is what we should aspire for? Again, same thing, no. If anything, most likely we'll hope that you'll get some response. Even stability of disease is good. And please remember, it's not all by size. We are really looking at dimensions of size, but could be also activity. In other words, if a patient comes and the doctors say the cancer is stable, means it's not growing or shrinking, this is good news as well. We don't really kind of like look at it as being something bad. And for that reason, don't please always look at the dimension of size. We like it. It's a good benchmark in a way, but more importantly, how are you doing? Always I tell patients is, first important, look at you. I can tell you, like I can examine patient the minute I open the door of the room for exam, because by the minute you look at the patient, you can tell how are they doing. And then you support that by the other things being radiology or the blood work, as Dr. Day mentioned to us about markers, etc. It's not really numbers or dimensions. It's really how are you feeling, how are you doing.
Great. So I'm going to do one clarifying point from a question that came in and then ask you a follow-up on that. So a patient asked, I was told about chemotherapy 8 years ago and that it didn't work well on liver cancer, but it sounds like it's being used a lot more. And the clarifier here is indeed, as you've been discussing, the range of options for what we can use to treat liver cancer has really changed and exploded in the past several years. And so if someone hasn't had a conversation with their doctors about this in many years, it's worthwhile going back to the team and asking about what's new, just as you've outlined. Now, another question that I think bears some more discussion is people are wondering, is the chemotherapy that people hear about with other cancers the same? And I think you mentioned that, but can you kind of expound on that a little bit more? People are worried if they're going to get sick, or are they going to lose their hair?
Yeah, sure. So again, this is a great question, and I kind of very happy to really reiterate that one more time. So it really kind of, could be a little bit, unsettling to me or irritating when somebody calls me, you are the chemotherapy guy. Because not only at all, actually, if anything, we barely give any chemotherapy when it comes to liver cancer, as I just mentioned. Chemotherapy, it means it's a certain toxin that can kill cancer cells. And classic example, we give it to pretty much all cancers. I think it started in the beginning with some forms of lymphoma. It evolves to leukemia. We do it for breast cancer, you name it. There has been attempts back in the 70s to try chemotherapy for liver cancer. Sadly, they did not work. And as such, those efforts kind of were disabandoned. And before the advent of the biologic therapy, it was like the default kind of, because we have nothing else to offer, let's offer. And I have to say that many of us actually even refused to offer it because we didn't have the evidence per se. Nonetheless, chemotherapy in certain evaluations was found to still benefit patients with liver cancer. It's not really a commonality at all, especially in the US or the Western Hemisphere, but we know very well in certain parts of the world, especially in China, it's used based on very really methodological and very rugged and solid data that ironically was published here in the US. So by all means, it can happen. So don't be surprised in the remote instance where your doctor might offer chemotherapy. However, the more importantly are what we call the biologic or targeted therapy, which I call the tyrosine kinase inhibitors or the immunotherapy. And as Jennifer said, the things have really mushroomed like incredibly positively in the last few years. We moved literally from one choice of therapy to literally, I need to even count on my fingers to really tell you how many there is. There's at least no less than 8 choices of therapy nowadays. So definitely there's way more options than you can imagine, which are along the lines of the targeted therapy and the immunotherapy as two main ones. And of course, the combination that came afterwards and really becoming a critical main one. And of course, chemotherapy as a backup plan, or at least you practiced in some parts of the world.
Excellent. And can you mention in general what some common side effects of the targeted biologic therapies or immune therapies might be?
Sure. So understandably, it's going to apply on which drug we're talking about, but nonetheless, side effects can vary. But in general, we know very well that the biologic or targeted kinase inhibitor therapy can cause some possible fatigue or tiredness. They can cause some skin-related matters. They can cause some possible diarrhea, and they might cause some possible weight loss. Hypertension can occur as well in some of them. But short of this, they are not chemotherapy of hair loss and the other things that you might have heard from patients who got chemotherapy. Immunotherapy is a little bit different. There is a chance that a certain patient might get immunotherapy and will even question their doctor if they're giving it to them because they might feel nothing. Because it can occur that side effects might not even happen. But on the other hand, we know that they could occur, among which mainly it's like an immune reaction happening in the body. It's like kind of, putting the body on like a little bit of a gentle heat, where joint pains, skin irritation, possibly some lung discomfort, some reactivation of a diabetes or a presence of new diabetes, thyroid function. These are things that your doctor might look at. In very rare instances, though, and this is something that your doctors will be very versed into, and please, we urge everybody always, whenever you're immunotherapy, whatever you don't like, whatever you question, always bring it up to your doctor, because certain instances, thankfully, they are very rare, where some things can be serious reactions to the side effects from immunotherapy. We have seen it, thankfully super rare, but please always bring it up, because yes, it can affect any organ in the body, because technically what you're doing is you're leashing out immune cells and you're making them work all over your body.
Great. And I think a clarification here as well is that all these medications you're talking about right now have been approved by the FDA and are available to patients. Now, where would clinical trials fit into what you're talking about today?
Great question. So if anything, yes, all what I'm talking about is already approved by the FDA. We have to be thoughtful if any of our dear audience members are outside the US. They have to be recognizant that not necessarily everything is approved in all countries. It doesn't mean good or bad, but the processes are different wherever we are. And by all means, it can be a certain limitation here and there. We have to remember, though, that the systemic therapy that we're talking about, as excited as we are and as excited that we're offering things to patients, we still sadly are unable to cure patients, exactly as we just agreed a second ago. And for that reason, clinical trial is going to be a very critical component, because we have to move the field forward. And if anything, the clinical trials could be either how can I enhance the current therapy to make it way better, improve it, and enhance it further, or number two, can I marry local and systemic therapy? We spoke about that a little bit ago. Or even can I come with a novel perspective? And I think, for example, at least I can talk about one hot item that many of us are involved nowadays, is how can we get to cure? And one thing, and I'm not necessarily saying that it's yet ready, but something we're working on, is definitely CAR T cells.
Excellent. And maybe could you just give a quick one-liner for people who may not know about CAR T cells, what they are?
By all means, thanks, Jennifer. Actually, great to kind of ask that. CAR T is same way. You remember I told you that you send the immune cells and the chairs and this. Now, actually, what we're doing, we're taking the immune cells from somebody, train them in the lab, and put them back in that person, not really trained to really see the cancer, but even to smell the cancer. So they will go after those specific cells that are the cancerous cells, because they know a specific antigen, or in other words, a certain piece from the cell of that cancer, and they will be able to know that they are trained to go after that specific and attack it. So that's really the concept in general. We know that they are approved already for certain what we call blood malignancies like leukemia, lymphoma. But on the other hand, definitely there's a big aspiration to really have them applicable for the solid tumors, among which, of course, is liver cancer.
I think that's a great reminder of how far we've come with liver cancer and how far we have to go. And it's like pioneers like you who have really led the field. So thank you for that. And a question for you specifically from the audience is, if Dr. Abu Alfa could only tell a patient one thing, what would it be?
Well, definitely faith. And I always say that to all of my patients, and some of you probably might be listening, and I say it in the clinic all the time. I always tell them, I learned faith in one specific temple or church or what have we, in that room in the clinic, because nobody will teach you faith better than a patient. And if anything, please have faith. Life goes on, and we all gonna be kind of ultimately, succumb to something here and there in life. This is, the risk of living, but at the same time, please always be positive. It's very important to continue to have, the sense of purpose in you as you move on in life. I love it when a patient comes to clinic and argue that they are late 5 minutes to see me. I tell them it means that you're doing well, because you're really trying to kind of make sure that everything is going on in life. And so by all means, faith is very important.
Wonderful, wonderful. There are some more questions coming in. One question is, what is the difference between chemoembolization and radioembolization, and are they equally effective, or would they be used in different situations?
That's a great question. Admittedly, we cannot compare them because they were never compared. Compared means that we put a certain clinical trial, some people get this, some people get that, and compare, see the outcome. This was never done. And by the way, I don't think it needs to be done, because you already in the question, whoever asked it applied already. Maybe they are used probably for different situations per se. If anything, the difference, number one of them is dependent on those little spheres, as Jennifer and I mentioned, that have chemotherapy in them. And the other one have little spheres that have actually radiation therapy in them. And along that route, there has been certain application to the chemoembolization to more confined disease, and same time radioembolization probably to more spread disease, because these things can transmit radiation further. And sometimes also you hear from doctors, if the blood vessels are involved, maybe radioembolization is more applicable than chemoembolization. Again, even though this could be subject to debate by certain doctors. But again, I would say not comparable, but applicable in certain situations, exactly as whoever asked the question implied.
And that really emphasizes also the importance of the multidisciplinary team approach. Oftentimes when patients have, for our programs, when a patient has liver cancer, we all get together and just explain this to the audience, because we're going to show this in just our next session, that we'll talk about the case, we'll review the specifics, we'll debate whether it's right to do chemoembolization or radioembolization or ablation or move to systemic therapy. So there's a real dialogue that happens as part of the multidisciplinary approach that is getting at exactly that question. A few more questions here, and all of us who see a lot of liver cancer patients, we're always reminded how each individual patient is very different in terms of their underlying liver disease, the stage of disease, and therefore what treatments we can apply to them and then how they respond. One question here is about a symptom. A patient has localized liver cancer to the liver, but has lost his voice, as an example. Is that a common thing that you see?
That has lost
his voice.
Lost his voice. Again, we're not gonna, and we have to be very careful not to start opening a clinic here, to be fair, respectfully, for the privacy, and number two, because we don't know all the details. But remember one thing, everything in our body is super connected to each other. And at least I give an example. It's not necessarily what the diagnosis or what the explanation is, but our liver sits on our diaphragm, and our diaphragm has certain very important nerves that travels through our chest. And sometimes if that diaphragm gets irritated because of the liver, that kind of nerve can actually cause a certain irritation that makes some hoarseness or some other problem in the body. So it can be as simple as this, but I don't want to come into diagnosis per se. But please, of course, talk to your doctor. He might explain better than we are able to do in that.
Yeah, I think that's a really important question, is that there are all kinds of different symptoms that people get. And so it's really important to engage your physicians in those discussions. We'll take this as our final question. The question is, does my diet and lifestyle impact how treatment works? Is there something I can do to help my treatment be even more effective?
So I totally agree in regard to the question of diet, and I'm 100% agree with my good friend, Dr. Today, is that we really, it's not about a specific diet. Everybody to kind of like just eat what they have to eat. I think the recommendation that they gave, which is, make sure that we enhance our proteins. We all live, this is how we all live, always live. We kind of have a main carbohydrate intake as breakfast, a protein lunch, and maybe a little bit of fat, and not every day, even for dessert, to have in the evening. And that's really kind of like really the measured approach, which doesn't really limit anything per se. Interestingly, though, it's very important to remember the liver is simply an industry, and we want to make sure that we really know how to handle that industry. And by all means, many of us know that sadly, alcohol, for example, can cause liver cancer. We really like very much that patients with liver cancer avoid alcohol altogether, because if anything, it really can affect liver functionality. And it's not sadly that we have another liver to really depend on. So short of that, I would say there's a really no clear limitation to anything, but there could be very important variations that at least I'll try to make sure everybody pay attention to. Number one, as you know, when a diagnosis comes to any of us, all our neighbors become the world experts on liver cancer. So they're going to all give their opinions. So please, we urge you, talk to us and make sure that we kind of give guidance regarding what cannot be used as an alternative approach, because some of them, it's not necessarily the alternative component, is it? But was it dissolved in, what's mixed with, can be hurtful to the liver. The number two component, on the other hand, sadly, in certain situations where we really are now dealing with a more cirrhotic liver, exactly as Dr. Day was mentioning to us, sadly, protein might become a problem. And we have to really kind of like gauge what's necessary to be done, because when people might become a little bit kind of, not as clear, sharp mentally as they could because of that high protein intake, because our liver is not able to maneuver all of that. And we end up with some things traveling through our brain that can make us a little bit confused or forgetful. So again, there could be variation here and there, but in that broad in between spectrum, do whatever you like, but of course, please avoid alcohol and any alternative approaches. Make sure you talk to your doctors.
Great, thank you so much. This is really such a wonderful discussion, and we are grateful to you and all the work that you have done on behalf of our patients and the liver community. We're going to take a break now. We're a little ahead of schedule, which is wonderful, because we're going to practice our squats that Dr. Today suggested, and we're going to have a nice protein snack in the meantime. And we'll come back at 12:40 when we begin the next session, which is about a panel discussion, a mock tumor board about liver cancer. So enjoy your break, and we'll be back at 12:40 Eastern Standard Time.
Welcome back, everyone. Hopefully everyone was able to get up, do a little stretching, get yourself some water, hopefully with the American Liver Foundation water bottle. This was a great first half of our session. I think everyone is getting a lot of information. We're getting a lot of great engagement with questions, which is fantastic. And the speakers so far have been phenomenal. We're going to bring back Dr. Guy, who is going to introduce our next section.
Welcome back, everyone. Hope you enjoyed your break. So we have some exciting content to still share with all of you. The next session is getting to know your team, and this will be moderated by Dr. Sheila Eshwan. She is an associate professor of medicine at Rush University in Chicago. She graduated from the University of Missouri at Kansas City School of Medicine, and then subsequently completed her residency in internal medicine at Maine Medical Center. She completed a transplant fellowship at the University of Nebraska, and then did a GI and hepatology fellowship at Loyola University. Her interests are broad, and she is very involved in liver cancer work, psychosocial aspects of liver transplantation, substance abuse, and alcoholic liver disease. Having worked with her on this panel, I can say that she is wonderfully warm and welcoming, and she also really gets the job done. So Sheila, please take it away.
Thank you, Dr. Guy. I appreciate that warm introduction. Yeah, so I think the audience can really understand and get a feeling that the theme so far has been team. As was mentioned by all the speakers so far, it is really important to identify a multidisciplinary team to help you on your journey through the diagnosis and treatment of liver cancer. So today, this segment here will be getting to know your team. You'll have the opportunity to hear from the various types of providers that will be involved with your liver cancer care. In many centers, the multidisciplinary team meets. We all typically sit in a room, review a patient's case, look at the stage of the liver cancer, the underlying liver function, and then we determine the best possible treatment options. For this segment, you'll hear from a hepatologist, myself, a surgeon, interventional radiologist, and a medical oncologist. For our surgeon on the panel, we have two surgeons, Dr. Alice Way, who is an associate professor of hepatopancreaticobiliary surgery from Memorial Sloan Kettering in New York. We have Dr. Ali Zaranpar, who is an associate professor in the Division of Transplantation and Hepatobiliary Surgery at the University of Florida in Gainesville. Our representative from interventional radiology will be Dr. Bo Toskic. He's an associate professor at Mayo Clinic in Jacksonville, Florida. And Dr. Ghassan Abu Alfa, who you've heard from, it will be our medical oncologist on the panel. And as you know, he's a professor of medicine at Memorial Sloan Kettering. So I will present a case and then give each member of the team an opportunity to describe their role. And this is typically what happens when a patient presents for a diagnosis of liver cancer. And you can get sort of a behind the scenes look of what we all do and what our roles are. So the discussion today for us will be based on a patient who is 73 years old. He has a good performance status, meaning he's pretty healthy. He's able to do the regular activities that he likes to do on a daily basis, you know, cooking, taking walks, spending time with his family. He does have hepatitis C, cirrhosis, and he was found to have a 3-centimeter liver spot on an ultrasound. An MRI was performed, and it did make the diagnosis of liver cancer, hepatocellular carcinoma. This particular patient has mild portal hypertension, which can be high pressures around the liver from cirrhosis. And this is shown by the patient having a little bit of a low platelet count and some esophageal varices. Esophageal varices can be dilated blood vessels in the esophagus and the food pipe. And those are some findings that can be seen with this portal hypertension. So he and the patient and his family are here today to seek an opinion about his liver cancer. So as a hepatologist, I see patients with all types of liver problems. So not just patients with liver cancer. I see people with new liver problems and chronic liver problems. I am sort of a primary care doctor for the liver. A hepatologist is a medical doctor that specializes in liver disease. So one of my major roles as a hepatologist is when I see patients with chronic liver disease that are at risk for liver cancer, I educate my patients and have them undergo screening for liver cancer. Once a patient has a diagnosis of liver cancer, my job is to confirm the diagnosis. So I will be looking at the CAT scan or the MRI to make sure that it does have characteristic features of hepatocellular carcinoma. And then I would stage the cancer in the chest, as was discussed. So one of my roles is to confirm the diagnosis. As was mentioned, a liver biopsy is often not necessary for this type of tumor, but sometimes we do need to do a biopsy to look for an underlying cause of liver disease or determine if the person has cirrhosis. So those would be possibilities, possible reasons why we would do a biopsy. And one of my roles is to determine if we need a biopsy. Once we have a diagnosis and a stage of cancer, I would talk to the patient about those things. And then my next job is to evaluate the cause of the underlying liver disease. As was mentioned, many patients with liver cancer do have cirrhosis. And so one of my jobs is to evaluate for the cause of cirrhosis. Oftentimes patients will come to me and ask, why do I have liver cancer? Why did this happen? And often the answer lies in the cause of their liver disease, whether it's hepatitis C, alcohol, fatty liver. So as a hepatologist, my job is to evaluate for the cause of liver problems. The next step for me is to look for evidence of cirrhosis or this high pressures, portal hypertension. It's important to know if someone has cirrhosis and portal hypertension as we make the next steps about treatment options. The way I do this is I do a history, physical exam, blood testing, and look at the imaging. And that is typically how we can understand the liver function, whether or not someone has cirrhosis and portal hypertension. There is times where we would need to do a biopsy of the underlying liver tissue to determine that as well. So basically, my job as a hepatologist when treating liver cancer is to assess the liver function and to support the liver function throughout cancer treatment. I'm sort of a quarterback for the liver as the patient goes through liver cancer treatment. So for this particular patient, I would see him, I would talk to him about his hepatitis C, determine if he needed to be treated for hepatitis C. I would evaluate him for cirrhosis, which it looks like he does have, and portal hypertension. And I would then take the patient and the information to my multidisciplinary team. During cancer treatment, I would see the patient in 2 weeks and then every 4 weeks to continue to assess the liver function and support the liver function so that we can maximize cancer treatment. So that's my role as a hepatologist. We're going to turn to Dr. Alice Way, who is a surgeon, as I mentioned, at Memorial Sloan Kettering. Nice to see you. Thanks for joining us.
Thank you very much. Well, I am a liver surgeon, and so in very similar ways to Sheila, who is a quarterback for liver medical disease, in many ways, liver surgeons are often one of the first doctors patients see when they have a new spot in their liver. So sometimes they know already that they have liver disease, as is in the case of this patient with a history of hepatitis C and who may have had very good follow-up in the past, an assessment of his liver function. Sometimes it's an incidental finding, or they have no history of liver disease, and the liver surgeon's one of the first people they see. So one of the goals that is important when I see a patient is to assess the status of their liver, to help establish whether their liver is healthy or there is underlying liver disease, to characterize the spot in their liver. So if they've had good quality imaging already, to help verify the number and the location of spots. And sometimes when the liver imaging quality isn't specialized for the liver, I often will order additional tests to characterize the spot in the liver more fully, and as well add additional tests for staging, such as chest imaging if necessary, and in other situations where the diagnosis may not be so clear at the beginning, additional tests, which may be endoscopy, upper and lower, or other additional tests, which can also include a biopsy either of the liver, and if it's not clear what the spot is, sometimes a biopsy of the spot as well. So those kind of specialized decisions are one of the jobs of the liver surgeon, and that's really the first thing that we do. And then once we have more information, as in this situation where the patient has a history of underlying liver disease, we already know that he has some cirrhosis and some frailty in his liver with some mild portal hypertension. Then the next goal is for us to look at the lesion, examine where it is. Since we already know by characteristics, it's very typical for hepatocellular carcinoma, and this patient is at risk. I would agree that a biopsy is not required at the moment, but then one of the most important things that I do as a liver surgeon is to evaluate and recommend whether or not there's a role for local regional treatment, whether that is surgery, so whether or not to recommend for surgery, or whether or not surgery may not be the best treatment for this patient, to think about other local regional treatments such as ablation, which we'll probably touch on in a little bit, and also to work in tandem with my transplantation colleagues about whether transplantation for this patient at this time in the future or may or may not be an option. So those are really the main jobs that I do. Even before we get to the actual operation, the main job is to diagnose, to recommend, and to see whether or not there's a role for surgery in his situation. So I don't know if you'd like me to comment at the moment about in this particular situation, whether or not I'd recommend surgery, but perhaps we want to get some input from the other members of the multidisciplinary team.
Yes, thank you. Dr. Ali Zaranpar from the University of Florida in Gainesville, who is also a surgeon. We would love your opinion also about the possible surgical candidacy for this patient.
Great, thank you very much for the opportunity to be a member of this team, as well as to really address our patients and the providers. Dr. Wei obviously did an excellent job really kind of outlining the role of the surgeon in this process. I'm just going to take a step back and kind of tell folks what the goal of surgery is at this point. Really, for us as surgeons, the goal is to remove the tumor cells and get clear margins. That's goal one. Another goal one is to preserve liver function, to minimize any risk for post-operative liver failure. You want to leave enough liver for the patient. And the third number one goal is to really, I mean, this is why we're here, is to increase the duration and the quality of life. So all these three really need to work hand in hand in terms of planning for surgery. So just getting into the nitty gritty of what the surgeon is looking at. The surgeon is looking at, where is this tumor? How big is it? How much liver would need to be removed to really get clear margins safely? How much liver would be left over? What's the quality of that liver? How much portal hypertension is there? Is there a lot of portal hypertension, meaning that blood really isn't flowing through the liver, it's going elsewhere, it's being diverted around? Is the tumor very large? Is it ruptured? Both large tumors and ruptured tumors can still be considered for resection, but these are risks. These both increase risks of recurrence. Is there tumor in the large vessels? Because if there is what's called tumor thrombus, so tumors associated with blood clots in big vessels of the liver, they can have poor prognosis in terms of not just local recurrence in the liver, but having metastatic disease. But there are cases, again, this is going to be dependent on the patient as well as the tumor biology, that if the resection includes removing some of those thrombosed vessels, some favorable results are possible. What are the other surgical risk factors? Is the patient basically going to make it through the operation? What's their age? I mean, age is just a number, but really it's age, frailty, performance status. Well, how good is their heart? What's their lung function, kidney function? Are there any other diseases that would be life-limiting? And then just in terms of, is there going to be enough liver left over after surgery? I think a lot of times this is sort of what the group comes together to discuss. What's the quality of the liver? How do you gauge the quality of the liver? It really is based on labs, especially platelet count is a big factor in terms of us determining or making a decision on how good the liver is. 100 is about sort of the cutoff that most people use in terms of whether the patient would be a surgical candidate or not. Some people use a MELD score that you may have heard about. This is a formula that uses a bilirubin, creatinine, INR, or you'll hear of a Child-Pugh score that uses a different set of labs and criteria. Those are bilirubin, albumin, how much ascites they have, how much encephalopathy they have, again, the INR. And these go into figuring out how much liver can come out. In someone with a totally normal liver, you can actually take out about 80% of the liver and leave only about 20%, and that'll be just enough for them. Once you get to some fatty liver disease or even up to child A or B cirrhosis, you can really get away with much smaller amounts of liver that can come out. What's in our arsenal in terms of how much liver we can take? Really, we can take as much liver as the volumes will allow us. And this can range from just taking a wedge, what we call a wedge resection, a small resection of the tumor that's on the side of the liver, to taking, doing what's called an extended right or left resection, taking about 3/4 of the liver. And how do we, let's say the patient doesn't have enough liver based on the tumor, how can we augment that? Does this patient have an option for that? Well, we can do things like portal vein embolization, which involves interventional radiology going in there, blocking off the blood flow to the side of the liver that comes out. What this allows is the side that's going to stay in, that side grows. You can do something similar with radioembolization before planning an operation. So sometimes these help, and we can get into the details, if people have questions about this. And then, we can get very complicated. We can do, take out the middle of the liver. We can take the whole liver out, cut a part of it out, put the liver back in. And this, these are, again, extensive operations that we can or may be able to do depending on the patient and the tumor. And of course, there's always the question of, is this patient better served by a transplant rather than just cutting a part of the liver out? And that, it's a complicated question. And I think that, if there is, if there is any doubt about that, then obviously the patient needs to be involved. And this is why we have a multidisciplinary team. That's why we all need to discuss it and obviously involve the patient and their caretakers.
All right, thank you for your insight. And I think we'll circle back to each of the panel members also when we maybe discuss this particular patient too. Dr. Bo Koschik is our interventional radiologist from the Mayo Clinic in Jacksonville, Florida.
Hi. First of all, I want to say thanks to the ALF and the program coordinators. Events where we can speak to patients directly are really the most significant. In brief, I'm an interventional radiologist, which is a new medical specialty. It used to be a portion of diagnostic radiology, but has since been recognized as a separate field of practice. There is now a sub portion of interventional radiology for those who practice and treat cancers of different types called interventional oncology. So some of you may hear of the term interventional oncologist, and that's what that is. Our job is quite broad because we basically access parts of the body in extremely minimally invasive means and do different things by instrumenting blood vessels, instrumenting tissue directly, and we do it for a lot of different purposes. We try to help out our surgeons. We try to get tissue so we can help our oncologists target things. We try to get information about the organ as to how diseased it is. And then we actually treat the cancers as well, as Dr. Abu Alfa mentioned so nicely, that it's a very broad way that HCC or primary liver cancer can present. And we have to really be pretty agile in terms of how we tailor the best therapy for the patient, given all these complicating factors. And that's really where IR touches the road for our specialty. Now, with respects to what we offer patients with liver cancer, and say in the case of a patient here who has a 3-centimeter tumor and has some degree of liver compromise where there is high blood pressure in the liver that does raise the risk for a conventional surgery, we really like to take a step back as interventionalists and say, all right, what's the cure for this patient? And by that, not so much what's the cure for this 3-centimeter lesion, but what's really going to extend this patient's survival and maintain their quality of life. And that's where, once again, right back to the multidisciplinary tumor board, we rely on our hepatologist to give us that insight and help guide us in terms of which is the overall trajectory for this patient to achieve that outcome. And with someone with compromised liver function, the first thing we would say is, are they a liver transplant candidate? Because they now have two hazards. They have the tumor hazard and they have their liver hazard. And interventional radiology will use different techniques to try to maintain someone as being a liver transplant candidate. So let's say if they are listed, there are certain rules where if that tumor goes beyond a certain size or a certain number, they can no longer maintain that candidacy. And so our job is to use our technique to keep them within that criteria. If someone is outside of that criteria at presentation, another thing that we'll do is use things such as chemoembolization, ablation, radioembolization to make someone a transplant candidate. And that's very important because there's now new data to show that that has actually shown improved survival for patients as opposed to some of the other things that we used to do where we would say that someone was not a candidate. And I think again, trying to make sure that everything that IR does on the front end to maximize that ultimate cure for both disease states is very important. So when it comes down to some of the ablative modalities that were mentioned, let's say again for a 3-centimeter tumor and a patient that has portal hypertension, you will hear radiofrequency ablation, and that is a form of thermal ablation. And ablation just means destroying tissue in place, much like a dermatologist would freeze something on the skin. We can change the temperature internally right around where the target lesion is and cause sort of a controlled destruction of that tissue. And the goal is to preserve the adjacent liver tissue, particularly in a fragile organ like a cirrhotic liver. Now, radiofrequency ablation was the most studied and the first technology to be used for this, but you may hear some other things that will be used. One is called cryoablation, which again, ablates tumors, but in this case by freezing it instead of heating it. And you'll hear about microwave ablation, which is just another way of generating sort of very controlled high temperatures in a very precise fashion, exactly where the tumor is. These are performed most commonly in interventional radiology by using image guidance. So you may or may not have general anesthesia, depending on your unique presentation, but the interventional radiologist will use image guidance, whether it's a CT scan or an ultrasound, place a needle directly into the tumor, and then check to make sure that there aren't any adjacent structures that will be damaged in the process, heat the tumor or freeze it, and then remove it. Remove the needle. After that, the tumor stays in place and the body's immune system hops in, walls it off with scar tissue, and it stays there. The benefit of that is that for right around 3 centimeters or less, in patients with some degree of liver dysfunction, it's actually a very strongly supported treatment and guidelines. Why? Because it does preserve liver extremely well. And that's very important when you take into consideration that most patients with cirrhosis have around 3 to 8% chance per year of getting a brand new lesion. And so you want to really make sure that if the patient's going to be living with that liver for the rest of their life, that you do preserve their remaining liver. Now, one of the things that we see when a patient has a lesion that's around 3 centimeters is that they are sometimes a little more prone to having some cells that are outside of what we can recognize with our scans. And that's really important because we have to know what to treat and what to leave alone. And that, the best way to think about it is a tumor, sort of a beehive, but you may have some bees that surround it. And 3 centimeters is where we'll start looking at, are there any other features about that tumor's appearance on the MRI? Or, for example, looking at how much of that alpha fetoprotein, which was mentioned earlier, that marker that's secreted in the bloodstream, if the tumor can secrete it, determine sort of what is the real risk for invasiveness of this lesion, i.e. there are hepatocellular carcinomas that are good players and there are ones that are sort of more aggressive players. And that will determine sort of how wide of a treatment zone will do, which goes into some of the other options that we had mentioned earlier, such as chemoembolization or radioembolization. Now, I counted several questions that came up sort of trying to differentiate between the two because radioembolization is sort of becoming more frequently utilized. And it is a dynamic process in terms of how we're choosing to use this therapy. It used to be that patients would get very advanced disease, would fail chemoembolization, and would get radioembolization as sort of a treatment that was meant for very, very advanced disease. What we learned was that, like any kind of treatment, if you can intensify the degree or the intensity of that treatment and spare normal liver, the outcomes are actually better. So what we have learned with radioembolization, it's actually useful to find a volume of liver that can be expendable to that patient over time. And that's the trick. When this is resected, that liver is removed instantaneously. But as Dr. Zarnpar mentioned, what we can do is find a volume of liver tissue, treat with very, very high intensity radioembolization. You may find this referred to, if you look it up on Google, as a radiation segmentectomy or a radiation lobectomy. But the goal here is to treat a larger volume of at-risk tissue with very, very high dose radioembolization. And that's really where we've seen better outcomes. And in comparison to things like chemoembolization, some of the evidence that's out there shows that patients will need fewer treatments if it's done this way. And actually one thing that's very nice is if it looks very good and a patient has that portion of the liver that sort of involutes, we'll circle back to our surgeons and we'll say, hey, do you think now this patient sort of has survived and has done well with this and the tumor's been controlled? Can you go in and do a completion surgery? And what we're finding is, not uncommonly, around sort of half the time, there's extensive, if not complete, tumor destruction with just that very, very high dose radiation. And again, I think that the dynamic here is that we don't just look at things like just size alone in terms of how we approach this. We look at how it's behaving over time under certain treatments. And the goal is to always try to circle back with a multidisciplinary tumor board to figure, okay, now that this has behaved a certain way, what can we do to try to get them to our best outcomes? And finally, I'll make a brief mention that a lot of these treatments that IR does, they're not necessarily in conflict with other treatments. Again, we try to make patients transplant candidates. We try to make patients surgical candidates. We will treat patients definitively with curative intent on our own. And we also like to work with systemic therapy. And there are a lot of trials in place right now, particularly in the immune arena, because we don't think that they necessarily are in conflict. And patients shouldn't necessarily only get one or another. There is potential, and we'll see what these trials will show. We don't have the answer just yet, but there is a lot of interest in saying, what if we treat this locally with IR techniques and also stimulate the immune system in the meantime? Do we get a combined benefit with that? And I think the timing and sequence of all that is so complicated that relying on your local institutions, best practice, those relationships, and really putting the patient first on top of all of those decisions is really where I think that it is absolutely critical to have a team approach to this.
Thank you very much. It sounds like the approach, interventional radiology and surgical approach are very complex, and it does require not just looking at the spot, the single tumor, but looking at the whole picture, the patient, the liver function, and there seems to be a lot of modalities. There are a lot of modalities that are options for treatment. So Dr. Abu Alfa with oncology, thanks again for joining us for this panel. Can we get your opinion about the role of an oncologist treating cancer, liver cancer? And I understand it's not just the chemo guy.
Well, thank you so much, Sheila. First, let's tell all our patients, dear ones, colleagues, whoever is listening to us today, we have a little secret to tell you all. We are actually, believe it or not, we come from every corner of the whole country or whole the world, and we are very close friends. We know all each other very well. It's a very, very small club, after all, in regard to the expertise in regard to liver cancer. And it's not unheard of that I might pick up the phone and call Sheila and say, by the way, can I get your guidance on this or that? We are very highly connected with each other. Don't worry, we don't hang out and we don't drink together, but we definitely talk to each other all the time. With this said, by all means, whenever patient comes to me, the first thing I do along that same line, I pick up the phone, I call Dr. Wei. I say, Alice, you sent me that patient, please teach me more. What happened, why, etc. It's very important to get the picture from what has been going on, because medical oncology, as we heard, we're not usually the first touch point. We are are having referrals from any of the expertise that come beforehand for that purpose. And if anything, we see ourselves as a part of the team. We depend, however, on learning from the team what has happened before. Make sure we use that collection of information. By all means, for example, what we can heard from Dr. Swaran, from Sheila, is what exactly the liver function is, because this might really decide what kind of therapy I might or might not be able to give. A certain intervention that has happened surgically might actually help me decide what to look at as being disease or not. We have a close connection with the IR groups, and Bo and I actually will go a long way in regard to discussing of different cases. Even we sometimes build on certain clinical trials together, because definitely we see the connectivity of critical importance to us. Now, all this said, besides getting the grasp of the details what's going on, I would always continue to say liver cancer is two problems in one: the cancer problem and the liver function. And I always pretty much say to any of my colleagues when they call and ask about I have a patient with liver cancer, beside the stage, I really need to know what exactly is happening with the liver. Liver functionality is a very critical component to really understand what's going on, because it might guide to us what exactly can or we cannot treat with. The very important part about liver function, and I'm sure Sheila, who is more expert than me on this, would agree, that it's not something of a pick and choose. You hear some of our patients might hear about something called Charpue scoring. Why use Charpue? Just by default. It's not necessarily the most perfect, but nonetheless, we use it. All trials have been done using it. So it's a good language for us. But it's not like a patient is either A or B or C by total random. It's not like an ice cream flavor. It is actually a continued process. And that process is actually not a linear function. It's not like it goes at the same rate. Actually, the historical thing, patient can be Charpue A forever. It's a long, long, long line from where I am in New York, all the way to California, around the world, and come back, and still long. Enough that patients might forget, even they might have heard that long time ago and they forgot totally about it. And that Charpue B is a curve and Charpue C is a shoot. And it's very important for us all, and that's why you can see the important multidisciplinary important component here, because our job is to keep patient Charpue A, because options are definitely readily available at that point in time. So by default, even though it is not really our expertise, but by default, we have to really, wear the hepatologist hat, or at least connect with the hepatologist to work this together. Then it comes to therapy. The therapy, it pretty much has to be geared based on what has happened beforehand, or what could be the extent of disease per se. And by all means, we are driven by what data is available, and the pick and choose will be based on what is appropriate for patient-specific situation, and at the same time what's available in that specific location, wherever the patient is, being in the US or outside the US per se. Very important though, and I please urge all the patients, don't compare notes. It's not always that, what works for you will not work will work for others, or what works for others will work for you. Things can be very different. And as you can tell, and already we employed it in different way, we don't treat diseases, we treat patients. And every patient is a very particular situation that really everything has to be super custom made for that specific patient per se. So I would not suggest that we say, okay, this patient got that therapy, that's why I should get one. Things can differ quite a bit among patients. Another important thing, when patients come to me and they really look at it, and I mentioned that beforehand, like, oh, that's it. No, it's not. Actually, if anything, I keep the whole team engaged, because I always say to patients with liver cancer, everything remains on the table. And if anything, we pick and choose what's necessary at the deemed appropriate time. And then others, is there a chance that I might ask back for the help of, for IR, and maybe get the input of, Dr. Tokish? By all means, I will. And I'll call Boa and say, by the way, I need your help here. So this kind of can be back and forth situation. So please, again, it's not like when you come to medical oncologists, it's the end of it. Absolutely not.
Thank you for that insight. So going back to our patient, as mentioned, he's a 73-year-old male with a 3-centimeter liver spot, diagnosed with liver cancer. He doesn't have any spread to his lungs, so he would be considered an early stage liver cancer. He has some portal hypertension, mildly low platelets. Dr. Wei, would you think that he would be a candidate for surgery?
Well, I think that, as Dr. Abu Afa just said, we have to treat each patient separately. He may be Child's A in terms of his liver function, but the mild portal hypertension does worry me a little bit. I would say the traditional Western approach is that patients with platelets in 100 or less generally had not previously been considered surgical candidates, but I do think that we do offer surgery for patients with mild portal hypertension. And I wanted to mention in particular for patients who only require a small liver resection. So it depends on the position of his liver. And in particular, if we're able to offer this patient a minimally invasive approach, there is, more of us will offer patients like this liver surgery. So we'd have to, a small liver lesion in a favorable location. So that's usually one on the edge of the liver, where the amount of liver that we need to take out is very modest. For patients in that situation, I do think he may be a surgical candidate. This is actually a perfect case for us to talk about at multidisciplinary rounds, because I would like to get the input of interventional radiologists, and because Bo had mentioned earlier about definitive ablation or definitive interventional oncology options for this patient, and for also a patient like this who's within Milan, who has a frail liver, which is okay now. I think also at least a discussion about whether liver transplantation may or may not be an option for this gentleman, I think would be also important. So with all those qualifications, the answer is yes, surgery may be an option for this patient. It will not be an option for every patient, though, with these characteristics.
Okay, thank you. Dr. Zaranpar, do you think this patient is a liver transplant candidate?
Well, absolutely. Absolutely a potential candidate. So Milan criteria, I think to simplify it for the listeners, really they're based on trying to predict which patients with liver cancer would have tumor recurrence after transplantation. There were many years where in the early days of liver transplant, people were trying to figure out whether transplant would actually play a role in treatment of liver cancer. And there were many failed attempts until the group from Milan figured out that if the tumors are within a certain number and size, that those patients actually do very well. And so the upshot is that this patient falls within Milan criteria, straightforward Milan criteria, one tumor between 2 and 5 centimeters, so would qualify in terms of tumor size and number. The question then becomes, well, what are you gaining from liver transplant versus the ablation or any other sort of local regional therapy? And that's something, again, to discuss with the patient. That's something to discuss with a multidisciplinary team. There's not going to be a right answer for everyone. And so, I think that having the transplant option on the table is certainly a good option.
And we know that there's no age cutoff, absolute age cutoff for liver transplant, but it's sort of a soft 70. And so if a patient is this age at 73, he might not, even though he meets Milan criteria, he's in transplant criteria based on his size and his number. There might be other factors that don't make him a transplant candidate, like his age or heart disease, if he had it. Okay, thank you. And so if the patient is not a transplant candidate because of his age, and maybe not the best resection or surgery candidate because of some portal hypertension, then Bo, what do you think would be your recommendation for the type of local regional therapy this patient might get?
So the first thing we'll do is try to get a sense for what we call the substrate, which is the quality of that patient's liver. And sometimes when patients present, they didn't even know they had liver disease. And so we want to really speak closely with our hepatologist to get a sense for, okay, this person's current status is this, but do you think there's anything active going on? Is there anything that needs to be addressed medically so we can stabilize this patient's liver function and give us a real sense that we're not sort of in an upward trend in terms of increasing liver dysfunction? Why? Because that really does affect how aggressive we'll be. And so once we get a sense for that patient's substrate, guided by the hepatologist, that lets us know sort of what we can get away with in terms of how much liver we'll have to treat for a given tumor's presentation. And that's important because, as was mentioned several times before, really the location of the tumor is very critical. When we are performing things like ablation, where we go and either heat or freeze tumors, its location as respects to other structures we're trying to not damage, such as bowel, stomach, or very critically within the liver, bile ducts, really does dictate how aggressive we can be. Guidelines will support that if this is in a favorable location, it is 3 centimeters, the patient has sort of stable liver function, even though there is some portal hypertension, that you can perform safely a thermal ablation and talk to the patient about potentially curing this lesion. I think that's fair. Particularly if you think you can get a good margin. Just like surgery, an interventional radiologist has to get a portion of the lesion and its normal liver adjacent to it to really ensure that we get it all. Now, if that can be performed, I think that's a very good option for this patient. It's actually probably one of the most common presentations we'll see. The patient has high pressures in their portal vein or portal hypertension, is not a resection candidate, and has very early or early stage liver cancer. Now, the problem is what happens to patients where we find that it is in a critical location where we cannot offer some of the heat therapies, like I mentioned, either freezing or burning, without damaging some of those structures. There are some other options. One is called irreversible electroporation, or IRE, which you may read about. It's still sort of in development as to where it exactly fits within guidelines, but it is a technology that allows us to essentially electrocute very focally a tumor and not damage the adjacent structures as much. Another one is where, again, going through the blood supplies, Dr. Abalf mentioned, we would treat the tumor through its blood supply. Now, that would be conventionally done with chemoembolization or bland embolization. But we are learning that if you provide Y90, again, in very, very high doses through the blood supply going to the tumor, it tends to not damage things like bile ducts or bowel, but it can very intensely irradiate these tumors to where we are beginning to see some results where they've had ablative effect, i.e. some patients are going to transplant. or going to resection after this. And we're seeing, gosh, like I said, about half of these patients are showing that everything was treated if you could treat it very intensely. Not every patient's always a candidate for that. Also using external beam radiation therapy, that's in development as well. They'll refer to it as SBRT, but it's a form of radiation therapy where, again, if it's in the right location and it can be approached, they'll go very, very narrow, the radiation oncologist, and will, again, provide a very, very high radiation dose. The whole objective here, again, is trying to identify patients who will benefit from therapy, i.e. folks who have preserved liver function, to where cancer is their main threat. Trying to identify where the tumor is and where it isn't. MRIs help with that, and like I said, staging helps with that. Is it in a location that we can actually tackle and really intensify therapy? A lot of heat, or a lot of cold, or a lot of radiation. Can we do it and get it all? And if a patient lines up for that, then they are almost always a local treatment if they have a 3-centimeter lesion candidate.
Okay, great. And with the, I have had a few questions from the audience. One is, this is a specific question for radiology. What is the quality of life with the radioembolization? So that is the blood vessel approach that induces and puts in chemo or radiation beads into the liver. What's the quality of life, and what would be the recovery time for that procedure, radioembolization?
It's a great question. So it really depends on how much is being treated by the radioembolization. So let's say if we take a patient that has a very small tumor and a very, very small volume of liver, it actually is one of the less symptomatic treatments that we'll do because the treatment effect, the radiation deposits over about 2 weeks, and then right around 3 months is really when we start seeing the effects of it. So it's sort of a slow transition where that tissue gets irradiated. If a patient has more advanced disease where it's involving both sides of the liver, we will see some fatigue that patients will experience. That's probably the most common thing that we'll see. Sometimes the white blood cell count will drop as well, and you can see that when you're getting your labs done. One thing that the interventional radiologist is going to be very, very keen on preventing is what we call radioembolization-induced liver disease, where in some patients they can even have some yellowing of their skin or jaundice that comes from sort of the radiation effects on the adjacent liver, particularly with advanced disease involving both sides. So we do things to calculate doses to make sure that we can avoid that whenever possible. But for the vast majority of patients, if they have radioembolization to a small portion of their liver, it's fairly asymptomatic. Some cramping is sometimes what's described if there's some inflammation in the early aspects of it. If you have more disease, I would say fatigue is something that I would expect most patients to anticipate.
Thank you for that. Another question from the audience. There's a few questions about communication styles for talking to the patients and family members about their diagnosis and treatment options. Because there's a panel of many different providers, would you say that there's a sort of one person that will be in constant communication with the patient, or is it the whole team all the time? I guess I'll answer that in that it really depends on where you are on your treatment journey. Sometimes you will present with an intermediate stage and you may see an interventional radiologist more often than you would maybe see a medical oncologist or a surgeon. And then if your tumor improves and you migrate earlier stages, as the tumor gets treated, you might see then a surgeon. And then if it progresses, you might then see an oncologist. So it really depends on where you are on the journey, but our job together is to communicate with each other, each individually communicate with the patient and their family. And then as a hepatologist, I sort of make sure that the liver stays strong and healthy throughout treatment. So I hope that helps answer that question. And then one last question is, what and how is a patient told how does a patient know if they're a transplant candidate? And if they're not a transplant candidate at one point, is it possible that they would be a transplant candidate in the future? I will ask Dr. Wei, could you answer that?
So that's a very good question. I think that the question about whether or not you can be sometimes a transplant candidate and sometimes not is actually a very good one. Usually it's very important at the beginning of your diagnosis to get an understanding about whether or not transplantation is something that is within the type of recommendations that would be a good thing for you or not as a patient. And if that's the case, I think it's important to see the transplant team early, to meet the transplant team, to discuss with them whether or not transplantation could be an option for you. And if it is not currently option, what are the kinds of things that would need to happen for transplantation to be a better option for you? So for example, initially the assessment for transplantation will talk about whether or not you're well enough and fit enough, whether transplantation is the right kind of treatment for you for the medical problems that you, conditions that you may or may not already have. And then they'll also talk about the type of the tumor characteristics. So often what will happen is that if the tumor initially is a little bit too big, let's say it's outside of Milan, so instead of a 5 centimeter lesion, it's 5.5 centimeters, then sometimes with treatment, which we sometimes call bridging therapy or downstaging therapy, some kinds of treatments can make the tumor a little bit smaller. And then we as a whole team will assess you iteratively. So each time you've had treatment to see whether or not the treatments worked for you, and then also keep an open mind throughout about how we would reassess the options in light of how the treatments work for you. And that applies not just to transplantation. So if the tumor is smaller, perhaps transplantation may become an option for you, but also when the tumor is smaller, perhaps liver surgery becomes an option for you, or further ablation or other treatments. So we all as a team will reevaluate each of our patients individually as they go through each treatment so that everybody will have a very tailored approach.
Right, thank you. And I think that's a good place to stop to highlight the fact that this is an ongoing conversation that we all have together. We meet weekly. We hear about patients with liver cancer once and then in a month, and then the same patient every 3 months as they go through their journey, and we go through their journey with them to support. So I want to thank everyone on the panel, and thank you to the audience for your attention.
Thank you.
And I think just to close the session, I wanted to thank all the patients and the caregivers for taking the time to join us today and to actively participate in learning about liver cancer and its treatments. I think you've all taken a major step towards understanding the disease and its treatment options. I don't have to tell you that getting a diagnosis of cancer in general and liver cancer in particular is shocking and scary. I mean, it can also be isolating, it can be confusing because oftentimes it comes out of the blue. But what you need to know, and it bears repeating, is that there are people, including my colleagues and myself, whose work is dedicated to caring for and treating people with liver cancer. And thanks to this work, despite decades of what may have felt like little to no progress in liver cancer, there are now multiple FDA-approved drug therapies, not to mention surgical advances and other advances in interventional treatment. So we as a medical community have gotten better, and we're working to get even better than that. When it comes to particular patients, I think it's important to really, to you as patients, do engage with your treatment team. Bring your questions, write them down. Understand the process, know what the limits are, know what the advantages and the disadvantages are, and the side effects. And so thanks again. And I wanted to close the session by thanking our sponsors, ASI, Exelixis, Merck, Bristol Myers Squibb, and a big thanks to our speakers, Dr. Tadei, Dr. Abu Alfa, Dr. Wei, Dr. Toskic, Dr. Eswaran, and Dr. Guy.
Excellent. Well, there is one more part of our day-to-day, and that is if you'd like to join us for Couch Conversations. What Couch Conversations is meant to be is an opportunity for people to connect. We know that community is important. We've talked about how team is important, not only with your medical providers, but also with the people in your lives. And so this is another way to think about how community might be able to help us through challenging times. So if you look into the chat box, there is a link with a Zoom number, and we will meet you in that new Zoom room if you'd like to join. Thank you, everyone, and we look forward to seeing you again tomorrow.